Hello and welcome to my YouTube channel. Today we are going to discuss one very important topic, and that is diverticular disease. But specifically we would be talking about the Hinchey's classification, the CT grading, the Hinchey's grade, which would help a surgeon to formulate a treatment plan for a complicated diverticulitis. So, as all of you are aware, diverticulosis, diverticulitis, and its associated complications is one of the commonest surgical emergencies and surgical problem which is seen, especially in elderly population. And the most important predisposing factor is obviously a chronic constipation, which can occur in an elderly patient, which leads to initially the development of diverticular, and then subsequently these diverticula may remain asymptomatic, or they may go on to develop certain complications like inflammation, which we call diverticulitis, or it may also cause one of the important complications, and that is the lower GI bleed, or it can also cause intestinal obstruction. So these are the complicated diverticula. So without wasting further time, let's specifically deal in this short video about what role a Hinchey's grade plays in formulating a treatment plan and how we can use it in our day-to-day clinical practice. So just a brief overview about what exactly is a diverticular disease and what are the terms used. So the term which commonly we use is diverticulosis, which is nothing but the presence of diverticula. And what are the diverticula? They are the acquired herniation of mucosa and submucosa through the muscular wall at the points of vasa recta entry. Now that point where the vasa recta enter into the gut wall is the weakest point of the gut wall. So whenever the intraluminal pressure rises, the mucosa and the submucosa may herniate through this muscular layer where the vasa recta enter into the gut, and that can lead to the development of diverticula, what we call diverticulosis, or the presence of diverticula without causing any symptoms. Now, most of the time, these diverticula are present in the sigmoid colon. That means on the left side, most of the time in sigmoid colon and descending colon in almost 70 to 80% of cases, especially in Western population, this ratio may be more skewed in terms of maybe more than 90%. Now this part, why this specifically this area, sigmoid colon? Because this is also the part of highest intraluminal pressure, and that may be one of the reasons why diverticula are more common on the left side, especially in the sigmoid colon. Now, what exactly is diverticulitis, which is a separate term which is used in relation here? There may be inflammation of the diverticula, and that would lead to diverticulitis. Now, this itself can cause further complications like perforation of the diverticula, leading to pericolic inflammation and abscess formation, which we would see subsequently. What are the risk factors we have already discussed? It is an age-related disease. Most of the patients are elderly patients, more than 50 years of age. Low fiber diet leading to chronic constipation is one of the important risk factors. Of course, there are other risk factors also, like smoking, connective tissue disorders, opioid use, which leads to constipation and chronic straining. So all these can predispose to development of diverticula. Now, there is a wide spectrum of diverticular disease, which can range from a silent, incidental finding on investigations to life-threatening complications like perforation or lower GI bleed. The Hinchey system stages the complicated, perforated end of that spectrum. That is the most important thing. So Hinchey's grading is specifically used for the perforation of the diverticula, which we would see subsequently. So the one on one end of the spectrum is diverticulosis, which is just merely the presence of diverticula, which are asymptomatic, and they are incidentally found when an investigation is done for some other condition. As we go on to the next spectrum, and that is uncomplicated diverticulitis. That means some sort of inflammation has occurred in that diverticula which is already existing, but that inflammation can only is confined to the diverticula. There is no associated complications like perforation or abscess formation. So this we call as uncomplicated diverticulitis. Then on the other end of the spectrum, we have complicated diverticulitis. Now these diverticula which are inflamed, they may go on to develop certain complications, like it can lead to perforation, it can lead to bleeding, and it can also lead to generalized peritonitis or abscess formation. Now, this complicated diverticulitis, especially the perforation part, would be staged by Hinchey's. And then there are certain chronic sequelae of long-standing diverticulitis, and that is internal fistulization, especially the ileocolic or colocolic fistula, intestinal obstruction because of hypertrophy of the muscular layer leading to luminal narrowing, or it can also lead to recurrent episodes of diverticulitis. Now, these are the diagrammatic representations. Diverticulosis, merely the presence of diverticula, and diverticulitis when they get inflamed, which could be an uncomplicated or a complicated one. Now, coming to our core topic today, and that is the modified Hinchey's classification, which is nothing but a staging system used for complicated diverticulitis, specifically the perforation of the inflamed diverticula based on CT and operative findings. Now, what exactly is this modified Hinchey's classification? Let's try to understand it in much better way. Stage 0 would be, by definition, a mild clinical diverticulitis. What do you mean by this term, mild clinical diverticulitis? That means the patient may have signs of inflammation like fever, tachycardia. There may be pain and tenderness in the lower abdomen, specifically in the left lumbar and left iliac fossa. And when you do a CT scan in such a patient, you would see bowel wall thickening with or without fat stranding, but there would not be any abscess. That means there is no evidence of perforation. That is stage 0. Stage 1A, which is a confined pericolic inflammation. That means there is a microperforation, but the perforation is just pericolic. On key CT findings of fat stranding, but there is no discrete collection here. 1B is a obvious presence of pericolic abscess. That means there would be an abscess which is confined and which is adjacent to the bowel wall. That comes into Hinchey's 1B. And what are the key CT findings? Here you would find small localized abscess which are less than or equal to 4 centimeters adjacent to the large bowel column. Then comes stage 2, which is a pelvic or slightly distant intra-abdominal or retroperitoneal abscesses. That is stage 2. Here there may be large or distant collection which are walled off. So the location of abscesses now moved away from pericolic area to either a pelvic area into the retroperitoneum or even in a distant region within the peritoneal cavity. That is stage 2. Stage 3 would be generalized purulent peritonitis, which signifies as a frank perforation leading to initially purulent peritonitis. So there is a free pus, and the whole peritoneal cavity would be flooded with this purulent fluid. And then the stage 4, which is the most virulent or most dangerous form of the diverticulitis, is generalized feculent peritonitis, where the whole peritoneal cavity would be filled with fecal fluid. That means there is a free perforation and fecal contamination of peritoneal cavity. So this is a modified Hinchey's classification, which is given in a descriptive or diagrammatic form as seen in different stages. Now let's go on to the management according to Hinchey's state. So coming to Hinchey's stage 0 and 1A, which is just a mild diverticulitis and confined phlegmon or confined inflammation with no evidence of collection. Here, what are the key CT findings we have already seen? There would be bowel wall thickening. There may or may not be pericolic fat stranding. But there definitely would not be any discrete fluid collection or abscess and no free air or extraluminal contrast. So it just signifies as a severe inflammation where there is no perforation of the bowel, but there is just a significant inflammation leading to fat stranding, and there is no free air or extraluminal contrast. So here the patient would present with left iliac fossa pain, low fever, there may be mild leukocytosis, raised C-reactive proteins, and if you palpate the patient's abdomen, there may be tenderness in the left iliac fossa and left lumbar region, and there would be localized tenderness and localized guarding may be present. In such a patient, what is the management in Hinchey stage 0, 1A? Generally, you can manage as an outpatient. If the patient is able to tolerate fluid, then you can give a liquid diet and give oral antibiotics. Or depending on the patient's condition, say patient has got certain comorbid conditions like uncontrolled diabetes or immunosuppressed, in such a case you can admit the patient and also give IV antibiotics. No other definitive or interventional surgery is required in such a case. Now coming to Hinchey stage 1B and 2, where there is a pericolic as well as pelvic or distant abscess, which we have already seen. Now here the CT finding would be in 1B would be a small abscess. What is the definition of small abscess? An abscess which is less than or equal to 4 centimeters, which is walled off. Or in stage 2, it may be a large abscess, maybe more than 4 centimeter, or it's a distant collection, say in the pelvis or in the retroperitoneum. Where on CT we can find a well-defined rim enhancing fluid collection which is confined. Patient would have clinically a persistent high-grade fever. There may be a palpable tender mass on abdominal examination, higher leukocyte count and C-reactive protein than an uncomplicated disease, and patient may have localized tenderness, guarding and rigidity in at the site of abscess. It may not be generalized, but it would be localized. In such a case, patient should be admitted in stage 2, 1B and 2. Give bowel rest. That means patient should be kept nil by mouth, nil per orally, or start giving IV fluids. Give broad spectrum IV antibiotics covering both gram-positive, negative, and anaerobes. If the abscess is more than 3 to 4 centimeters, under under selective CT guidance, that abscess can be drained percutaneously under CT guidance if it is more than 3 to 4 centimeters. If the drainage fails or if the abscess cavity persists, then we can do a planned elective sigmoid resection. Planned elective sigmoid resection. But most of the time, if the abscess cavity is more than 3 to 4 centimeters, then percutaneous drainage under CT guidance would be effective. If it is less than 4 centimeters, we can give antibiotics and bowel rest, and most of the time the abscess cavity would resolve. Coming to Hinchey stage 3, which is a generalized purulent peritonitis, where on CT findings there would be a free intraperitoneal fluid as well as pus. There may not be any direct communication with the bowel lumen, and there would be diffuse fat stranding suggestive widespread inflammation across the peritoneal cavity. In such a case, when you palpate the patient's abdomen, you would have diffuse abdominal tenderness. There would be guarding also, diffuse, as well as rebound tenderness suggestive of peritonism. There may or may not be signs of sepsis like tachycardia, fever, and hypotension. Generally, the patient would look unwell in such a case. Now, this is an emergency where the patient should be admitted, managed under high dependency unit. Patient should be resuscitated with IV fluids, bowel rest, broad spectrum antibiotics, keeping a close watch on patient's vital parameters, and as soon as the patient becomes stable, immediate urgent surgery should be done because this will require exploratory laparotomy. Generally, the procedure involves peritoneal toileting after exploratory laparotomy, resection, resection of the perforated segment of the bowel, along with creation of a, either you can do a primary anastomosis with a diverting proximal loop ileostomy in a stable case, or if your patient is unstable, then a Hartmann's procedure, which generally involves excision of the diseased gut, proximal end colostomy, and closure of the distal rectal stump should be attempted. So, in a nutshell, after resuscitation, immediate surgery, if your patient is stable, give a thorough peritoneal wash, do a primary anastomosis after excision of the disease segment, and do a proximal temporary loop ileostomy to protect the anastomosis. If your patient is unstable, then the best procedure to be done is, rather than doing a primary anastomosis, do a quick Hartmann's procedure and plan for a restoration of bowel continuity after 4 to 6 months. In Hinchey stage 4, which is nothing but a generalized feculent peritonitis, the findings would be obviously free perforation with luminal communication. There's a gross fecal contamination of peritoneal cavity, and there is obviously an extraluminal air and oral contrast leak or CT contrast leak also. In such a patient, the clinical picture would be a severe generalized peritonitis, diffuse abdominal tenderness, guarding and rigidity diffusely. Rebound tenderness would be present. Abdomen would be silent and rigid. That means bowel sounds would be absent. Patient most of the time would be in septic shock with hypotension, tachycardia, and this stage carries the highest morbidity and mortality. And the mortality and morbidity would increase along with a presence of comorbid conditions or elderly patient. In such a case, emergency laparotomy should be done. Hartmann's procedure is the procedure of choice in such a case. That means you excise the diseased part of the gut, do a proximal end colostomy, and do a closure of the distal rectal stump. Avoid doing a primary anastomosis as done in a stage 3 because of gross contamination of peritoneal cavity. Damage control surgery should be done because most of the time the patient is generally in septic shock and unstable. So in such a case, Hartmann's procedure is the procedure of choice. Later on, post-operatively, you can carry on the resuscitation in the ICU setting, and once the patient stabilizes, plan for a restoration of bowel continuity after 6 to 9 months. That should be the treatment protocol for Hinchey stage 4. What investigations generally we do in such cases? Of course, contrast enhanced CT abdomen and pelvis is the gold standard, which not only confirms diagnosis but also stages severity according to Hinchey staging, which we just saw, and it also helps therapeutically, especially in grade 1, guides drainage and also helps in decision making whether to do surgery or not. Of course, you have to do routine lab parameters like leukocytosis would be seen in full blood count, C-reactive protein, urine analysis, lactic acid levels, especially if the patient is in sepsis, blood cultures if the patient has got fever. Ultrasound is a reasonable alternative when CT is unavailable or especially in pregnancy. But the only flip side of ultrasound is it's operator dependent. Colonoscopy should be avoided in acute phase of diverticulitis because it can lead to risk of perforation as the bowel wall is friable and inflamed. So colonoscopy should always be performed 6 to 8 weeks after resolution to exclude any associated complications or associated pathology like malignancy. Erect chest X-ray or abdominal X-ray can be done initially looking for free gas under the diaphragm, especially in a perforated diverticulitis. But CT remains the investigation and gold standard investigation of choice. So this is the management algorithm. Just to recapitulate, in stage 0 and 1A, give oral or IV antibiotics with bowel rest, and if it is a mild disease, you can manage outpatient. So this is the only thing which is required in stage 0 and 1A. If the patient is in stage 1B or 2 with abscess, IV antibiotics with drainage of abscess under CT guidance percutaneously if the abscess is more than 3 to 4 centimeters. Less than that, bowel rest and IV antibiotic should be enough. Stage 3, resuscitate and immediate surgery, maybe resection and primary anastomosis if your patient is stable. with a proximal diverting ileostomy. In stage 4, where there is a feculent peritonitis, emergency laparotomy. There may not be time for resuscitation, continue resuscitation as the surgery is proceeding, and Hartmann's procedure, which is excision of bowel, proximal end colostomy, and closure of distal rectal stump, is the procedure of choice. Severity rises from left to right, escalate from antibiotics to drainage to surgery as the Hinchey stage increases. So this is the relevance of Hinchey's staging. Now, what are the surgical options available here? We have Hartmann's procedure. We have already seen what exactly it is. It's a sigmoid resection with proximal end colostomy and closure of distal rectal stump, which is standard for stage 4 patients or unstable patients. Always do reversal or restoration of bowel continuity, at least not before 3 months. Resection and primary anastomosis with a diverting loop ileostomy should be done in stage 3 patient where the patient is stable and contamination is limited. Laparoscopic peritoneal lavage, washout and drainage without any resection may be done in selected stage 3 cases only, but it is controversial and depends on center to center. Damage control surgery where the limited resection can be done in very unstable hemodynamical patients. So just to sum up with complications of diverticulitis, apart from perforation, it can also lead to hemorrhage where there is a painless diverticular bleed, most common cause of major lower GI bleeding. Fistula, we have already seen. Colovesical fistula is one of the commonest one. Ileocolic fistula or colocolic fistula can also occur. Colovesical fistula should be suspected when there is a nematuria or fecal urea, that means air or feces in the urine. Can also develop colovaginal, coloenteric fistula. Stricture formation or intestinal obstruction because of chronic fibrosis from recurrent attacks can occur, and recurrent risk is always there in diverticulitis. Risk rises with each episode. Consider elective resection after even a single complicated episode of diverticulitis. That is a very important point, that because of repeated episodes of recurrent episodes of diverticulitis, a single complicated episode should be the reason for an elective resection or a sigmoid colon resection, or 2 or more episodes of diverticulitis should also be an indication for elective resection. So one complicated or 2 uncomplicated diverticular episodes. CT is the investigation of choice. Just to recapitulate, never colonoscopy in acute stage. Hinchey's stage on CT drives the treatment pathway. Any abscess more than 3 to 4 centimeters, percutaneous drainage should be attempted first. Hartmann's remains standard for stage 4 unstable patients. Colonoscopy should only be done 6 to 8 weeks post recovery to rule out other pathologies, especially malignancy. With that, we come to the end of this short presentation. I hope you have found this video useful, and if you found it useful and informative, kindly subscribe to our channel and please share with your colleagues and batchmates. Thank you for watching and thank you for your time.